JVS Journal Club. And so I'll go ahead and make some introductions while we're letting a few more people in. So there we go. So this month, it's January, it's 2024. New year, same me. New year, new journal club though. So we have two great articles that are going to spark a lot of discussion, I think. So the first is the financial burden associated with endovascular repair of thoracoabdominal and pararenal aortic aneurysms using physician-modified fenestrated-branched endografts, which I'm excited to have a robust discussion on. And then the second article is symptomatic carotid webs require aggressive intervention. We're thrilled today because we actually have the young surgeon section of the SVS hosting this particular journal club. And we have young surgeons from USC as well as WashU. And even within the authors, we have some younger surgeons. I like to think Bjorn Suko is young. He was my resident years ago. So to me, he's always going to be young.
That's very kind of you. Thank you, Misty.
From the Washington University, we have Dr. Wankin, who is in the Division of Vascular and Endovascular Surgery. And then the resident is the second-year resident in vascular surgery, who is Dr. Chavukala, who's going to be presenting. And then from Keck, we have Dr. Greg McGee, who's associate professor in the Division of Vascular and Endovascular Surgery. And then his fourth-year integrated resident, Dr. Anand Ganapathy, who is going to be covering and presenting their article. From our author guests, we have Dr. Clayton Brenster, who is at the University of Chicago and co-director of the Center for Aortic Diseases, and the PGY1 integrated resident, Dr. James O'Leary. Dr. Bjorn Suko, who is at Dartmouth Hitchcock, and then Dr. Sadia Alayas, who is an assistant professor at MedStar George Washington University. Just a few housekeeping things. Oh, sorry, and our special guests, our moderators, also from the Young Surgeon section, Dr. Kendall Endicott, who is the director of the Complex Aortic Surgery Program at the Uniform Services of the Health Sciences, and also at the University of Virginia, and then Dr. Sen, who is an assistant professor at Mayo Clinic. Just a few housekeeping things. We ask you to please stay muted. We are going to ask you to put your questions and comments in the chat so that our moderators can call on you to speak. As you just saw, this is being recorded for on-demand access later. And then, of course, we are going to have our February version. And right now, it is slated to be on Valentine's Day. I might be able to get the host institutions to switch. But if you have no other plans, you can spend Valentine's Day with us here at the JVS Online Journal Club. So at this point, I'm actually going to turn it over to Dr. Weaver so that she can say a few words about the Young Surgeon section.
Thank you so much. So first of all, thank you, Dr. Humphreys, Dr. DeMuzio, and JVS for allowing the Young Surgeon Section Research Work Group to take over the January JVS Journal Club. I think most people on here probably know there's been an effort over the last couple of years by SVS to create a Young Surgeon Section, and the intent of that is to meet the needs of early career vascular surgeons, and that means anyone in their first 10 years of practice or still in training. So early on, when the YSS was developed, a survey went out to ask YSS members what areas they wanted us to emphasize our efforts in, and research was one of the top priority areas that people were interested in YSS resources and programming. So from that was born the YSS Research Work Group. And one of our goals as a research work group is to really highlight the incredible work that early career vascular surgeons are doing academically. So tonight we have chosen two articles that really were led by Young Surgeon Section members. And we have discussants that are, as Dr. Humphreys mentioned, from the Young Surgeon Section. So we're really excited about this effort. We really appreciate everyone participating, and we hope to generate some great discussion tonight.
I think at this point, we'll turn it over to our first faculty member to start presenting, and we'll go from there.
I've got my screen shared if everyone can see it.
That we can.
Excellent. Well, thanks so much for the invitation to speak tonight on behalf of the Young Surgeon section. And as Dr. Humphrey said, I'm Zach Wonkin, and I'll be providing this introduction for Dr. Chivakula, who's actually one of our senior fellows coming out of training this summer. We have no disclosures. So as I said, my charge is to provide an introduction so that Dr. Chivakula can provide an overview of this article from Dr. Ilias and Dr. Zuko. I thought it'd be nice to first go over a little bit of a background on the financials of infrarenal repair. Looking first at this paper from 2000, which showed that at that time, when EVAR was relatively new on the landscape, the cost was substantially more than open repair at about $20,000, as opposed to an open repair cost of about $12,000. And that was primarily driven by device cost, which we'll see as a theme throughout this. Moving forward about a decade, here's another paper which shows that EVAR cost is still about 35% more than open repair at that time. Moving forward another decade, we kind of look at the change to the Medicare diagnosis related group change between 2014 and 2015 in comparison to 2017, 2018. Over that time period, as you can see, the technical cost increased unsurprisingly from about $25,000 to $26,000. But at the same time, the technical margin increased for hospitals, making this a more financially viable operation between about $6,000 to about $10,000. Since that time, obviously, more and more institutions have implemented complex repair programs. And the literature has shown that there has been basically variable financial viability, depending in part on the local regional Medicare carrier for each individual location, as well as participation in investigational device trials. I think this is particularly pertinent as ZFen has obviously been on the market for quite some time and has been FDA approved. Whereas we're right around the corner to have the TAMBI device available from Gore and on the market. And as we saw earlier, it's really the device cost that drives the cost for these procedures. And there are substantially more devices that are involved with that operation as opposed to ZFen, which is on the market. And so with that, I'll turn it over to Dr. Chivakula.
All right, if you just exit, I'll share my screen now. So my name is Sitaram Chivakula. I'm a senior fellow at WashU in St. Louis. And I'm presenting this paper, the financial burden associated with endovascular repair of thoracoabdominal and pararenal aortic aneurysms using physician-modified fenestrated-branched endografts. I thought this was very interesting just because, as a trainee, this isn't a side of the operation that we are usually thinking about or is in the forefront of our minds, aside from, the little note I get on Epic at the end of the case saying the total device costs. So just as a little bit of background to follow up what Dr. Wonkin was talking about, as we all know, PMEGs and EVARs are something that we've been using to treat complex aortic aneurysms, and where we use off-the-shelf devices and customize them to the patient for their visceral and renal anatomy. As Dr. Wonkin had stated, there's papers in the past showing that EVAR does have a higher immediate cost than open repairs, and this is largely driven by device costs, and PMEGs do require significantly more implantable devices. So looking at the increased overall costs in order to determine what the financial impact would be for continuing these operations and what the procedure associated costs and operating margins for these operations would be. So this was a single center study, retrospective study between 2017 and 2021, looking at a single surgeon's experience over 4 years. Because it was a single surgeon, the device types and costs were generally consistent. The modification procedure was standardized over the course of the 4 years. It did include all physician modified grafts and excluded any Cook ZFens or industry sponsored trial. The specific financial costs and revenue data was collected directly from the hospital, and this was broken down into several categories. The technical costs were the device costs and the billable supplies, the things that we think about when we're talking about the device costs driving the cost of these procedures. The professional costs were taken from OR time. And in this study, they did not look at any of the indirect costs associated with these surgeries because they are variable between institutions and regions of the country. Revenue for these operations were calculated based on CPT and diagnosis related group reimbursements, and then from these reimbursements and costs, the operating margins were calculated. So first, look at the demographics. Over the 4 years, 62 patients met the inclusion criteria, predominantly male with thoracoabdominal aneurysms with a mean size of 6 centimeters. 63% had Medicare payer sources, which will become more relevant as we break down the costs and reimbursements. And then I think one interesting note is mean of 8.6 implantable devices with 2.6 aortic devices per case, which becomes relevant when we talk about device costs. Looking at the total of the 4 years, from the bird's eye view, the total costs, the total device costs were really what drove the direct cost in these surgeries, with the total technical direct costs coming to about 70% from the devices. Comparing direct cost and remuneration for all of the patients in the cohort, the technical cost mean was about $71,000. The revenue was about $57,500, which had a mean net negative margin of $13,500 per case. And then looking specifically at what led to the technical cost, the devices were 77% of that $71,000 cost. Looking a little further into the Medicare payer group, which was about 50% of the patients examined, the technical cost was significantly greater than the revenue, with a total net negative margin of almost $23,000. And again, 79% of this cost was related to the devices. So this graph basically shows the revenue comparing to Medicare patients versus non-Medicare patients. In the non-Medicare patients, the average net positive, the average margin was a net positive of $7,900, whereas, as I stated before, the Medicare margin was a net negative $23,000. And then again, looking at the professional costs, so not the device costs in this situation. In both the Medicare and the non-Medicare patient groups, they both had an overall net negative professional cost margin when looking at the cost and the reimbursement. So just discussing what this data tells us, I think it was useful because this is a real world analysis of a single PMEG program. This is real world data of how a single surgeon operates on these patients and sets up their operations and devices. Looking at the Medicare patients, the technical reimbursement was alone, did not cover the device costs themselves. So this leads into a discussion about, can we change hospital margins to make PMEGs a more sustainable practice for hospitals, as well as if device costs are what's being the main driver between the high financial burden on the hospitals. The device costs are negotiated between the hospital and industry, and moving forward, cost reduction is going to be crucial for maintaining a sustainable PMEG practice. One thing of note is that this study did only focus on the index operation, so it did not include any staged operations. It did not include workup, follow-up imaging, anything like that, which would be additional sources of revenue when looking at the big picture when talking about complex aortic programs. Professional reimbursement does vary, so that is another limitation that of the study, that you can't compare between different institutions. So again, limitations doesn't include stage interventions, reinterventions, follow-up care, follow-up imaging, or the overall draw that complex aortic care may provide to both patients and other providers as a referral basis. But the takeaway points are basically that as it stands now, physician modified endografts are substantially negative operating margin, especially when your patient mix is primarily Medicare payers. And that negative margin is largely driven by device costs. As we said, these device costs may affect the sustainability of a PMEG practice or complex aortic practice, and this may increase the burden on institutions and widen healthcare disparities, especially when the Medicare payers are operating at a higher net negative margin. So moving forward, talking about increased reimbursement and cost limitation may make PMEGs a more sustainable and equitable practice. So, thank you. I'm looking forward to any discussion.
Thank you for all that background information and excellent summary. And really thank you to the authors for this contribution to the literature. As we saw, there have been a few articles of this kind of type in the past few years, but I think this one does a really good job of articulating some of the major problems that I think a lot of centers face financially with some of these complex aortic cases. And this is certainly a topic that's very poignant for me, starting our complex aortic program and recently being asked by our institution to look at our cost margins. And so I think we're going to have questions that are going to start coming in. But the first question I'll ask the authors, what motivated this study and how difficult was it for you to extract this financial data from your institution?
Maybe I'll take the first half of that. Just thanks to our colleagues at WashU for doing such a nice job reviewing our data. It's very neat to hear you talk about our work here. Thank you. What motivated this? Here's my full disclosure on this. PMEG in my mind is a stopgap, right? Ideally, I would never have to modify a graft in the future, and this would all be industry supplied. And that would ultimately allow for bundled costs, single provider, single industry sponsor that would ultimately bring everything I need. And that we know is associated with lower costs. Right now, we're stuck doing a hodgepodge of multiple different devices, and that already inflates the cost quite a bit. So the motivation here was to inform industry that is now coming to the table with new devices. Gore TMB will be FDA approved within the next year, we anticipate. There are some other devices that are coming into IDE trials. And we wanted to do our best foot forward to show you what sort of the current benchmark is, where we're losing money, and hopefully help our industry sponsor partners to understand where to put their cost price tag, right? For example, the Gore team had talked about a $65,000 sticker price for the TAMBI device. If you put that against the numbers that we're collecting on reimbursement under the current DRG, there's no way that would be a viable exchange. It just wouldn't work. So that was the motivator. But let me defer to Dr. Ilyas, who was my fellow at that point and is now at MedStar, about how easy or not so easy it was to get this data.
Thanks, Dr. Zuko. So getting the technical costs and data, some of it is very granular in nature to be able to get from your financial center. I think Dartmouth had a couple of caveats that make this is probably an underestimate for what most institutions are facing, just based off of this is going to be very institution dependent. And there were some caps on some of our devices as far as cost moving forward, kind of the number of devices that we would use. And so just comparing kind of the New England data or the Dartmouth data, even though it's still striking, it's probably still an underestimate of what people are facing across the nation, and it's probably harder to get that data at in other avenues.
And the other thing I'll throw out is it's virtually non-disclosed what other institutions have contracted for their cost of these devices. And I think that's a disservice to us as a community of vascular colleagues trying to do this in a collective way and improve what we're doing. I have no idea what my colleagues down the road are paying for the same exact device. And putting some of this out in the literature, I hope will stimulate discussions like these and maybe some way to just transparently talk about, hey, what are you paying? What are you negotiating? And maybe we can follow our European colleagues and talk our industry partners a little bit lower on the cost part.
That is so true. One of our first questions here from Dr. Humphreys: when we have looked at cost in the past, we have sometimes looked at the entire hospital course, post-procedure imaging, and follow-up. Do you think that those areas allow for recuperation of money lost?
I think that's a great question. And globally, there may be some improvement of the margin. I don't think it'll net even with all the follow-up. Here's why, especially in our neck of the woods, we have a very broad geographic catchment area, and many of these patients will get follow-up images locally. I will have telehealth visits with them and review them, and as long as things are good, we're good to go. If they're part of our own clinical trials, we're a little bit more vigilant in bringing them back. But even within our own trials, as you look at the follow-up data, 50% over 5 years are alive, and maybe 1/3 to a little bit more are actually on par for routine follow-up, just like most of the other EVAR publication data. And so I think it's hard to say that that will be viable as a break-even point. We're essentially losing money doing these procedures, but our boss puts it in a really nice way. He says, at least you're doing it in an elegant way, right? This is part of a bigger picture. This is part of a bigger program. This is a net negative or a loser part of a larger program that is still viable and ultimately in the black. And that's because it attracts other referrals. It attracts prestige. It attracts other patients that want to come and get taken care of by you because you're doing something that can't be done elsewhere. So I think, at what point do you say that this is a money loser versus a money gainer? Do you look at all imaging? Do you look at readmissions? Do you look at duration of follow-up? Do you look at the influx of referrals? Do you look at the type of cases that you now get to do because you're doing this? It's hard to argue that.
Yeah, it's a tough conversation sometimes, though, to have with the finance office, for sure. Do you have any idea how our European colleagues do in comparison? Are they financially viable? If so, why? This is from Dr. Kanamed.
I have a little insight into that. The biggest one there is that their contracted costs for these devices are substantially lower than ours. They also, depending on which payer system you're talking about, the NIS, if you're looking at Germany, if you're looking at Sweden, they may cap the number of these cases that you're allowed to do, endovascular cases, to make it financially viable. They actually concentrate these types of surgeries in certain centers of excellence and mandate referrals. So there's a lot more centralization and oversight involved. I think that makes it financially a different topic. The other one I'll just sort of tangentially talk is, if we put here, our European colleagues are paid much less than we are in the US, right? And a lot of us are RVU incentivized. And these cases are associated with some of the highest RVU counts out there. I personally, if I were to be paid by RVUs, would make a lot of money doing these kind of cases, while the hospital as an institution would lose money because of the cost of the devices I put in. So there's a complete disconnect even between the surgeon and sometimes with hospital leadership here in the US, and that makes it difficult too.
Additional question from Dr. McGee: has your hospital contracted directly with insurance carriers for reimbursement for elective cases? And has that been able to improve your revenue?
Dr. Ilias, do you want to comment a little on the breakdown on our Medicare versus private cohort and how that varied?
Yes, of course. So a little over half were Medicare, from a Medicare payer source. And so I anticipate that, especially as we start to utilize these more and more, that number is going to increase. And that's where we lost the most amount of money, almost twice as much as we did from private insurance, patients with a private payer source. And then between the payer sources, there are still some differences between cost, although less statistically significant between those. So the biggest difference seemed to be between the Medicare and the non-Medicare payer sources in general.
Yeah, and a lot of our private insurers, we have contracted with them to ensure that these are covered and reimbursed, and that tends to be at a much higher rate than Medicare does still. In fact, if we were to break them down in our private payer cohort, there are many who actually had a positive margin because of the level of reimbursement. The other thing, this is another sort of tangential point. We don't have a clear DRG for these codes, right? If you're talking EVAR, you're looking at 268, 269. Where does the thoracoabdominal, the pararenal aneurysm fall? At what point is it the thoracic one, which is a much higher reimbursed DRG, the 220, 221s? And if you're doing a type 2 thoraco, great, that's a pretty straightforward one. But does a type 4 really fall under that one? Does it not? Do I have a say in which DRG actually gets coded and sent off, right? That's where a lot of the disconnect occurs as well. So ultimately, we would have a different DRG that fits for these kind of procedures. I think that would be a big boon forward. And that's, again, one of the incentives for doing this kind of work. Hopefully get a new code or some sort of reimbursement group for this put together.
Question from Dr. Beeman. 77% of cost is from devices in your study. Industry is taking advantage of those doing this work. What are all the administrators doing about this?
I think that varies place to place, institution to institution. If you're talking about hospital administrators, ours are aware and haven't said a thing about it because in the global scheme, we are still being more productive year on year. We are doing more cases. We're attracting more business. And in the large scale, this is still not that big of a loser compared to the other things that we're doing. And so our administrators are doing virtually nothing about it.
Well, there's a lot of information. They make a lot of money and they're not doing anything. So I think we'll leave it with that little tidbit and we'll move on to our next article. Thank you, Dr. Suko. Thank you, Dr. Endicott, for a great discussion. Dr. McGee is now going to open up our next presentation.
Thank you very much for that introduction, Dr. Humphreys. So, and thanks for the opportunity to present today. We're going to move on to the carotid web paper, and I'll just give a little bit of a background on our carotid webs. There's not as much out there as there is on financial burden of PMEGs, so this will be pretty quick. So carotid webs were relatively recently described in the 1960s. That's probably after endarterectomy was being performed. So they are a thin membrane of tissue that extends from the posterior wall of the ICA and bulb into the lumen. It's thought to be a relatively rare form of fibromuscular dysplasia, although I think we'll talk a little bit about that in the discussion, about whether or not that is an accurate description. Commonly found in patients with cryptogenic stroke, and so it's an important potential cause of cryptogenic stroke, and a predominance in young patients, female and African Americans. So interestingly, after Dr. Brinster paper came out and I had a chance to see it, I had my own patient with carotid web, my first ever, and so it was very timely. This is an ultrasound from her. Oftentimes you can't see the carotid web on the ultrasound, or it's missed by the tech or the person reading the imaging. As you can see from the one image on the right, it can be relatively difficult to see or obscured. Oftentimes the stenosis is less than 50%, and occasionally you can see some intramural thrombus. So that would be an important finding. One of the better ways to evaluate this is on CT angiogram of the neck. It's best seen on the sagittal and the coronal planes because it can often be missed on axial images and sometimes confused as a focal dissection. On these first two images are patients of mine who had some intraluminal thrombus, which is free floating here. And then this is the second one is after a couple of weeks of treatment with anticoagulation. And then the third one is just another focal web. Also can be seen on angiography. This is important because you can actually see the dynamic nature of the flow. And so this is one of the almost sine qua non of this diagnosis. So it's important to obtain lateral views. So you're splaying out the external and internal carotid artery, which sometimes can be missed if you're doing a suction thrombectomy, as one of our neurosurgical colleagues or neurointerventionalist is doing that, and they're just quickly trying to get up into the ICA and not necessarily doing formal evaluation in the bulb. But when you do splay this out, you can see it again in the posterior lateral border of the carotid, And importantly, on these three images, you all can see, or these three sets of images, the washout is fairly delayed in that area behind the web, consistent with recirculation, and that can lead to thrombus formation and ultimately the cause of strokes. Intraoperative findings. So here is an example of kind of the cul-de-sac that you can see right there on the middle view, and then another one here with a more of a fail-like morphology. And oftentimes you can actually see thrombus within that cul-de-sac there. It's important to get that cul-de-sac out and do an informal endarterectomy there in a patch. And then the really interesting thing is that there's not definitive guidance on the optimal treatment for this. It's a relatively rare disease. It hasn't really been reported a lot in the literature. And this is, I think, why this paper was so interesting, has gotten so much interest. So for symptomatic patients, what should be done? Should it be medical management with dual antiplatelet therapy, as you would do for strokes without a carotid cause, carotid endarterectomy or carotid stenting, or either of those are fine? It's not really exactly clear. And then what's even more unclear is what to do about asymptomatic patients. And so that, I think, leads us into the paper. And I will segue over to Dr. Ganapathy. Who is our current fellow, and will be discussing the paper. Thank you.
Thank you for the opportunity to present Dr. Brinster's and colleagues' work with the Young Surgery section for the January Journal Club. So Dr. Brinster and colleagues performed an observational study with retrospective review of prospectively collected data at a single large comprehensive stroke center from 2016 to 2022. Cases of suspected symptomatic carotid web were reviewed by a collaborative team of vascular surgery, vascular neurology, and neuroradiology to confirm the diagnosis. Diagnosis involved multiple imaging modalities, as well as rule out of other causes of stroke, including cardioembolic sources. Treatment included carotid endarterectomy by vascular surgery under general anesthesia with patch angioplasty or primary closure, while carotid stenting involved either transfemoral stenting with distal embolic protection or transcarotid stenting with flow reversal by vascular neurology or vascular surgery. All endarterectomy specimens were sent for formal pathology analysis. A total of 52 patients were identified with symptomatic carotid webs during this 6-year period. Symptomatic webs were more commonly found in women and African Americans, as Dr. McGee had already said. Symptomatic presentation with stroke was most common, with only 2 patients presenting with transient ischemic attacks. 91% of the strokes were MCA territory strokes, with the other 4.5% being anterior circulation strokes, and the remaining 4.5% being combined MCA-ACA territory strokes. No posterior circulation strokes were seen in this population. The average NIH stroke scale on presentation was 8. Few patients had traditional risk factors for strokes, including hypertension, smoking, diabetes, or oral contraceptive use. And only 14 of the 50 had more than one of these traditional risk factors for strokes. Carotid duplex was the initial imaging modality for these patients to evaluate the carotid artery. However, the carotid web was not diagnosed on any of these duplexes. The webs were instead diagnosed using CT angiography or cerebral angiography. While these modalities have better three-dimensional imaging capabilities, the carotid web was still missed during initial review for 67% of patients. Further, the vast majority of these patients did not have significant carotid artery stenosis, which would commonly increase the awareness for a carotid stroke of source of the ipsilateral stroke. This may explain in part why these webs were missed during initial review. Additionally, 25% of the patients were identified to have bilateral carotid webs. Early in their experience, patients with symptomatic carotid webs were managed medically with dual antiplatelet therapy or systemic anticoagulation with statins. However, within an average of 43 months, all 10 patients treated medically presented with recurrent strokes, with half having permanent disability. The authors concluded that medical management of symptomatic carotid webs is not sufficient. So these patients and future patients were offered intervention, either carotid endarterectomy or carotid stenting, unless a severe disability precluded intervention. Definitive treatment was performed by endarterectomy for 27 patients and stenting for 23 patients. 2 patients had irrecoverable deficits and were not offered intervention. Patients with acute anterior distribution strokes requiring aspiration and thrombectomy underwent simultaneous carotid stenting. Non-urgent and elective cases underwent endarterectomy. The average interval from initial stroke to intervention was 39 days, with missed or delayed diagnosis and outpatient carotid scheduling contributing to this delay. At a follow-up of 38 months on average, there was no reported post-intervention stroke or death. This series represents the largest single-center experience in diagnosing and treating carotid webs, while also comprising 25% of the total cases reported worldwide. The majority of these reports are single case studies. However, when the authors compare their data to published data, they found similarly high rates of stroke recurrence with medical management, while seeing comparable high rates of success with minimal complications with treatment, either by endarterectomy or stenting, highlighting the importance of intervention and the failure of medical management for carotid webs. There are many factors that make carotid webs difficult to diagnose, including the low occurrence of this condition, comprising just 10% of cases for embolic stroke of unknown source, while lack of typical stroke risk factors that would raise a provider's suspicion for a carotid source, young age of patients, and female gender all contributed as well. Further, the imaging findings were easily missed. As Dr. McGee has already said, the keys to success include evaluating sagittal slices on CT or MR and lateral projections on angiography. Marked contrastasis and/or delayed contrast washout should also be considered pathognomonic for carotid webs in patients with embolic stroke of unknown source. Based on their endarterectomy experience, the author described 2 distinct phenotypes of carotid webs: the veil morphology shown on the left and the prism morphology shown on the right, which have technical implications during endarterectomy. Specifically, the veil can be feathered in a straightforward manner, while the prism requires formal segmental resection. In addition, historically, carotid webs were thought to be a form of fibromuscular dysplasia. However, the authors propose webs be thought of as separate and distinct entities from fibromuscular dysplasia based on the following fundamental differences. Their locations are different. The webs are more commonly posterior lateral bulb, while fibromuscular dysplasia is more mid to distal cervical and internal carotid artery. Their appearance, the linear shelf-like projection versus the string of beads, the involvement of the intima versus the media, and honestly, and more importantly, their treatment, with webs being treated by either endarterectomy or stenting, whereas fibromuscular dysplasia could be treated with plain balloon angioplasty. The authors note the following limitations associated with their work. In particular, the treatment strategy for asymptomatic carotid webs, which lacks data and requires further study to reduce the conversion to symptomatic webs. In summary, carotid webs are often misidentified and misdiagnosed. Care should be taken to closely evaluate imaging of patients at high risk for webs. Medical therapy is not sufficient to prevent recurrent strokes, while conversely, intervention with carotid stenting or endarterectomy is both safe and effective at preventing stroke recurrence. And finally, multi-specialty teams of vascular surgeons, vascular neurologists, radiologists, and stroke specialists can help in the diagnosis and treatment for this rare condition. Thank you.
Thank you for that awesome presentation and the introduction. We already have questions here. So I'll start off with one from Dr. Hingorani here to Dr. Brinster. And he asked that how did the authors select CA or CAS? And does the degree of thrombus affect this selection?
It's a great question. First, I want to start off by thanking the Young Surgeon Society for the kind invitation to present our work here. It was a collaborative effort among all the authors and multiple specialties at Ochsner Health. To answer that question, as our experience evolved and we noted more adherent clot to the posterior web space and on detailed review of imaging, including angiography and CTA, when we noted that high percentage of adherent thrombus as noted in the manuscript, my feeling is, and the interventional neurology team at Ochsner's feeling became that stenting should be reserved for patients that are undergoing concurrent aspiration thrombectomy in the setting of acute anterior distribution stroke, because the interventional neuroradiologists at our institution and of course at others also have a unique armamentarium in that they can both aspirate and treat acute embolic stroke and also treat the carotid bifurcation with stenting. And so my feeling is that endarterectomy is preferable in the elective setting, the non-emergent setting, I should say, because even with a high-powered CTA, we have found that thrombus has been missed, and we've discovered it intraoperatively on gross exploration of the carotid. And so I worry about manipulation of the carotid bulb, the posterior web space, wires, stent deployment, even getting a distal embolic protection device up into the internal could be fraught with problems. And so my recommendation would be endarterectomy is preferable unless it's in the setting of acute stroke and aspiration thrombectomy.
That's wonderful. And I see some more questions coming up here. I'm going to mix up some of this stuff. So Dr. Kavasde, I hope I didn't mess up your name, on the topic of thrombus asks that how do you differentiate it from the web? And is it on CT or DSA? I know some of these are detailed in your paper. And also, how do you manage for a free-floating thrombus? And that's from Dr. McGee, if you do find it on the carotid.
Sure. Well, I'll address Dr. McGee's question first. In general, we approach these in a fundamentally different way than you would say a cardiac embolic event to the carotid bifurcation or a spontaneous rupture of a plaque or severe ulceration that results in a flame sign or floating thrombus. In that situation, we would approach that in the well-established fashion to expose the carotid and not clamp the internal and let it backbleed after a carotid arteriotomy. Once there's established backflow, then clamp the internal and proceed with whatever intervention you see fit. The thrombus we've observed either on imaging or on exploration of the carotid in situations of carotid web has been unique from that we've probably all seen in the situation I just described, in that the thrombus has been localized to the web space. The largest thrombus I saw that I regret not including this image in the paper, it very impressive thrombus that's probably 2 centimeters in length, but it's well formed. And that's what we've seen really, is that the majority of these thrombi that we've seen do not have a fresh appearance. They have almost a platelet plug, a mature platelet plug appearance similar to that of subacute or even chronic thrombus. So it's a great question. I think you have to have a very high index of suspicion for propagating thrombus in the internal, especially because this is not a diagnosis that is straightforward in any way, even with our experience at Ochsner. And it does require, for that reason, I want to emphasize again, a multi-specialty approach, because oftentimes these patients would present with a subtle finding, a repeated TIAs or a mild stroke in a young patient with a very subtle finding in the carotid bulb, even on high-powered CTA imaging. And so conversations with a neuroradiologist, a neurointerventionalist, and a vascular surgeon can oftentimes elucidate the proper approach. I do have to say, and I think Greg and Dr. McGee and I spoke about this, and other people that have reached out to contact me about web-like findings in the bulb, is that I have not explored yet a carotid and had a negative exploration when web is suspected. I have thought several times that I may not find anything, and it's always a web. So I'm not saying, based on this relatively small series compared to, say, the numbers of embolic stroke of unknown source that you may see at your medical center, that that's always going to be the case. But if you have a young patient with a negative echo who's had an anterior distribution stroke, and there's a subtle finding in the bulb, especially if it's posterior lateral, where 100% of carotid bulbs form, we can talk about that in a bit, I think that patient mandates exploration. If you have a negative exploration, it's a relatively low morbidity procedure. But if you manage that patient medically, as we've seen in our series and others, and there is a web, the recurrent stroke rate is just unacceptably high. And I start my presentations on this topic with the story of an unfortunate 39-year-old who had 3 recurrent strokes within 3 weeks and was hemiplegic on his dominant side. And so I think that when in doubt, like transferring a patient to the unit or putting a chest tube in or intubating, as we've all been taught, if you're thinking about it for too long, I would explore that patient. I think a negative exploration is better than kind of rolling the dice on a young patient and risking a recurrent stroke.
That's wonderful. And I just have a question of my own before I move on to the one from Libby, that do you ever consider an eversion for these patients, or is it always is it always the conventional, because then you get to look at that lumen much better?
Yeah, it's a good question. Eversion is not part of my practice. Don't let Rich Cambria hear that. But the reason I think eversion would not be effective in these patients is because the location of the web in 100% of patients in our series and others is in the posterolateral bulb. It's always kind of displaced from the origin of the ECA, which leads me to believe there's an embryologic origin in terms of the involution of the aortic arches. I think it's the third in the case of the external and internal. It almost looks like there's an incomplete involution of the origin of the external there. And so an eversion really would not treat the pathology because it's so far proximally displaced.
Wonderful. And now moving on to the one from Dr. Weaver. So what do we do with the symptomatic web with an asymptomatic contralateral? And then that kind of segues into surveillance if we are not intervening for these patients.
That's an excellent question. The asymptomatic web contralateral to the symptomatic web is something I've seen twice, and I've offered endarterectomy to both those patients for the asymptomatic side. They were both young patients. One was 28 when she had her first stroke. The answer is we don't really know, but my feeling is that for those patients, both were under 40, one was under 30. Thankfully, both had a recovery after an initially debilitating stroke. But my feeling is that they've already proven that they have some sort of pathophysiology, pathologic anatomy that produces a potentially devastating stroke on one side. I am not comfortable, if it were my family member, leaving the other side alone with medical management, even without evidence of a anterior distribution stroke. I will say that we've been in communication with radiologists who are doing sophisticated analyses, both of the post-web space and the actual web, in terms of stress analysis and other analyses that are beyond the scope of the discussion. But in terms of asymptomatic management, that I think will yield dividends in terms of how we approach these patients, because the more I hear about them, the more I hear about them. And that there's just increasing reports in the literature because embolic stroke of unknown source is getting so much more attention now. CTAs are performed so routinely in our ERs for patients with neurologic symptoms. We used machine learning at Ochsner just to try to identify anything stated in radiology reports, carotid web, focal dissection, filling defect in the bulb. And it's in evolution now that my colleague, James O'Leary, who can speak a little bit more about some of these issues, and I are not at Ochsner anymore. I wonder what is going to happen with that. But we had identified over 300 patients with asymptomatic web in one institution. And now, granted, the demography of the New Orleans and Southern Louisiana area is unique, I think, in terms of carotid web incidents. But they're out there. It's just a question of looking for them. And so that's an active area of research.
Wonderful. And there's another question here about the type of stent. Is it a covered stent, bare metal? How do you choose?
Yes, that's a good question. All the stents in our study were bare metal, all except for one that I did a TCAR on, I think an 83 or 84-year-old who had a web, were placed in the acute setting.
The next question is a part of the question from Dr. McGee, and that deals with the anticoagulation that you use peri-procedurally and even before intervening if somebody is presenting with a thrombus, and what's your protocol for that?
So if there is thrombus, I usually remain with dual antiplatelet therapy. Our experience in the few patients that were managed with systemic anticoagulation, they all had recurrent strokes. And so I don't know that there's a difference, or do we have the power to say whether it makes a difference or not? I think if there is thrombus, systemic anticoagulation is always the kind of the knee-jerk reaction. I don't think that's wrong. I just think that we don't have enough real data to suggest what we should do in that situation. And I'm
Got
sorry,
it.
the second part of that, was there a second part of that?
No, it was just a protocol for the preoperative thrombus management, but you answered that for us. And then Dr. Weaver again asks, how do you develop a niche practice like this? And this is, I think, more.
Well, it's a good question. I think that the first one of these I saw, unfortunately, was that 39-year-old unfortunate patient I mentioned to you. Maybe I didn't read enough for my written boards. I had never even heard of carotid web. I'd certainly never seen it in my training. And if you look back at some of the editorials in our own journal about reviews from the non-vascular literature, there is a lot of doubt about whether it even existed, or isn't it just FMD? Shouldn't it be treated the same? And that goes to show that there are busy carotid surgeons with decades of service and experience in our field who have seen maybe one. And so I understand the doubt and the lack of defined information out there. I was fortunate in that Ochsner Health has a huge stroke referral center of nearly 60 referring institutions in Southern Louisiana and Mississippi. The other thing I will say is that there is a predilection for young African-American women in our series and the other largest multi-center series called CaroWeb that's been developed out of Bordeaux, France. And the reason they have a big series and the reason we have a big series is because I firmly believe there's a genetic link to West Africa, and the main island that they've identified carotid web in and the main populations they've identified it in France are similar to the populations that emigrated to the Southern Louisiana and Mississippi area. And so that's another area of potential investigation. So I took it and kind of ran with it. I spoke with the chiefs of radiology and interventional neurology at the beginning of the series, and it started gaining traction when we got over 10. And then everybody kind of bought in, and we developed kind of a group that was dedicated to carotid web. We talked about a lot of cases together, et cetera. So I think you really have to have the patience and the interest and a multi-specialty approach. And just one thing I want to mention, because I alluded to it, and James O'Leary here, who was a fourth-year medical student, contributed some critical analysis and organization to this study when we were both at Ochsner, and is now a first-year integrated resident at Beth Israel Deaconess in Boston. He and I looked into separating carotid web from FMD classification because there was so much doubt in our own literature about it. So James, maybe you can highlight a few of those differences and the work that you did.
Yeah, thank you, Dr. Brinster. I mean, as a medical student, I thought maybe carotid webs were the norm, seeing you guys see a couple every month. But, Dr. Ganapathy had a really great table, an elegant table in there comparing the difference between carotid webs and FMD. If you look at the literature, some of the previous literature described carotid webs as an intimal variant of fibromuscular dysplasia, but I think it's pretty clear now based on looking at both the demographics we found and pathology reports looking at carotid web specifically being intima, some myxoid degeneration, and this unique patient population specifically that we saw a lot of in New Orleans is a very interesting future to study and important to acknowledge. And I see another question in the chat, how do we raise community awareness of this? By defining the disease through this study and looking maybe at the future, if we could look in the lab a little further and defining it and defining its best treatment for patients is really important. So I definitely am excited to see, what the future holds for it.
We do have a few more minutes, so I'm going to try and squeeze in a few more questions here.
Sure.
So one of it is, you mentioned that, there is a lot of misdiagnosis. So in your own experience, when you went back or you pulled out those 300 patients, did you find, okay, this is probably it, and this should have been a web? And then what did you do with those patients?
The asymptomatic patients, we haven't done much of as far as I know. In terms of the misdiagnoses, when we look back at the experience of why that occurred, there were a couple things that stood out. One was that with a huge stroke referral center, the people in the community really rely on you to do everything, but they may interpret the study. And so it's kind of a whisper down the lane thing that we all deal with transfers. If someone gets branded with a diagnosis, if you get called and say, oh, there's a rupture, you start preparing for a rupture, you start looking at it through the lens of a rupture, and maybe it's not. So I think a couple things led to those misdiagnoses. One, a lot of these diagnoses were made initially in the community, where if at the highest level of our society, we're still getting educated about this condition, you can't expect community radiologists and surgeons to know what it is or be able to diagnose it. And commonly, these patients came in with acute stroke. They get choppered in, they go right to the neuro lab, and the radiologist, even at our institution, I think in that situation, they're under duress. They're looking for a cause of potentially devastating anterior distribution stroke. So when they scroll very quickly through thousands of images, they look in the axial projection. My feeling is for a devastating source or etiology in the carotid bulb. If there's not a massive plaque, if there's not a thrombus, they tend to try to figure out where the money is and where that embolus came from, and look at the distribution of clot in the brain to guide therapy. And so they see something that looks like a focal dissection. Well, that's really not going to cause a M1 or M2 MCA occlusion and a potentially devastating stroke. And so on to other potential etiologies. If there's not one established, that patient still needs emergent therapy. They go to the lab, they have aspiration thrombectomy. In rightly so, in the rush to get those patients aspirated, we saw that the guiding sheath was often driven up past the presumed to be normal carotid bifurcation. The intervention was done, the completion film was done, everything was withdrawn, the patient goes to the unit. And so that was one. The sheath was positioned too distally in some patients. And in some patients, the images were shot in an anterior-posterior configuration or anatomically AP. And so if you look at most carotids in AP, the bulb is obscured by external blood flow. And so if there's contrast in the external, it's impossible to see a web in AP distribution, unless you're looking for delayed washout, which, as Dr. McGee mentioned, we consider to be pathognomonic for carotid web until proven otherwise. It really requires looking, one, at the sagittal sections of a high-powered CT of the head and neck. If you want to see a web, it is always best visualized in the sagittal section because of the splaying of the external and internal. And the same is true for cerebral angiography. You really need a lateral shot to look for that shelf-like projection in the posterior lateral bulb. I have to emphasize where 100% of webs are going to be found. And then the delayed washout, which is evident of a carotid web.
Wonderful. Dr. Kranz asks, how do we raise community awareness? I suppose you touched on it, but I guess educating our colleagues down the line, because at least I also am in a community kind of a practice here.
Yeah.
I practice out of Wisconsin, so I do see the benefit of that.
Yeah.
We seem to see a lot of people with ocular problems here, and pretty similar to this topic, very not described, but it's so common. But I'll let you talk a little bit more about that.
Yeah, I think that's an excellent point. And the whole aim of this study was, yes, it's really interesting because it's relatively new in terms of how much we know about it. But the potential to save young patients, especially from potentially life-altering or devastating stroke, is really a powerful potential that we have as vascular surgeons with carotid web. And I think the next step would be a national registry. And to accomplish that, we just need buy-in from the society and more publications about it and more knowledge. And again, that's another great feature of the kind of invitation that you gave us to speak about it tonight. But I think that's the next step. Unfortunately, does not fit into the parameters of the low frequency consortium because there's no designated CPT code for carotid web. But there are avenues, and we're looking into how best to start at least a regional collaboration. Now that I'm in Chicago, there's interest at Indiana University from radiology, and hopefully anyone who's tuned in tonight, please contact me. I'm eager to collaborate about this.
Wonderful.
So in the spirit of, sorry if you don't mind me interrupting a little bit. So
absolutely.
in the spirit of the young surgeons section, to piggyback on Dr. Weaver's comment about, how to develop a niche, I think what I really love about Dr. Prinster's paper is that, he goes from the East Coast to a different location where a disease process was relatively exceedingly rare to where it's seemingly there all the time, and nobody else really talks about it. I mean, when I was Googling over the last couple of days to prepare for this presentation on carotid webs. One of the things that popped up was a Twitter post from my co-fellow, Catherine Bowser, who's big on social media. And she posted a picture of the first carotid web she had operated on. And the first person to comment on it was Ross Naylor, who said in 1,200 endorectomies he's performed in his career, he's never seen one.
Wow.
And it just goes to show that it's just sometimes the local, the demographics you see in your locale are different than other places, and then offers you the opportunity to study something that no one's ever done before. And I think that is often true for everybody out there in different locations. There's got to be something that's unique to your center that you're seeing that maybe other people aren't seeing. And I think that's really, to me, remarkable at this paper. So.
Well, I appreciate that, Greg, and I appreciate your interest in it and support of it. One thing I will say is that, yes, the final project is something that we're all proud of, and the patient number is high. This project got rejected in one form or another at least 5 or 6 times by program committees at pretty much every meeting you could think of. And that was a blessing in disguise, because I remember Chip Sternberg saying after I saw my first 1 or 2, if you get this series to 10, it will likely get on the podium at the VAM. And that was certainly not the case, because it got rejected there and innumerable other meetings in its evolution. And the reason I say it was a blessing in disguise is because we learned a lot more about web along the way. And despite that, the main focus of why I bring that up is because if you believe in something and you know it to be true, if you really want to study something, just don't give up on it. You can have the stuff that's going to generate you presentations or notoriety, or you can get involved with research that's a home run. But my dad, who's a genetic researcher, always used to say, keep 10 or 20% of stuff that's going to really drive you and make you excited. The other 80% is going to be boring, and you have to do it, and that's what generates income, and that's what sustains your career. But you got to hold on to something that makes you passionate. And I just want to say again, this got rejected at pretty much every meeting you could think to submit it to, and it led to multi-specialty collaboration that was not really firmly established before that. We got medical students with a lot of talent and drive like James involved. And so that would kind of be my concluding message, and just another thank you for including us.
Yeah, Clay, thank you so much, and everybody involved. Libby and Greg, really super happy to have you guys on board. And let's do it again in July with your group. Much appreciated. And on behalf of Misty too, thank all the presenters, the faculty mentors, and in particular the authors for their great contributions to the journals. So we'll see you guys next month, I hope.
Perseverance is a virtue. Thanks,
Amen.
everybody.
Thank you.
All right, bye-bye.
Bye, thanks.